Dr. Yoshito Kadoya. He trained extensively in Japan, in particular in Kyoto. So he finished his internal medicine, cardiology, and interventional cardiology in various centers in Kyoto. He also did a structural heart disease fellowship in Japan. He's moved to Canada and has been doing a multimodality imaging fellowship at Ottawa Heart Institute since 2021. That includes some time working in both CMR, cardiac CT, nuclear cardiology, including SPECT and PET. So without further ado, Dr. Kadoya is going to be talking to us about coronary microvascular dysfunction.
Good morning, everyone. Thank you very much for having me today. And thank you very much for a kind introduction, Dr. Miller. First of all, I would like to thank Lexi for arranging my schedule. And I'm also very grateful to Dr. Miller and Dr. Howard for inviting me as a speaker today. Today, I'm going to talk about coronary microvascular dysfunction. This is the photo of the Kinkakuji Temple in Kyoto, Japan, which is my hometown. And so if you have planned to visit, I would be very happy to share some local information. So let me start. I have no COI disclosures. So this is today's outline. First, I'm going to talk about a brief overview as well as pathophysiology of coronary microvascular dysfunction. Then I will talk about invasive assessment of CMD, followed by non-invasive assessment. And finally, I will touch on treatment for coronary microvascular dysfunction. Right. So this slide shows the coronary macrocirculation, which is essentially visible coronary arteries. Historically, we used to manage ischemic heart disease based on the coronary angiography findings. However, as you know, we recognize that coronary microcirculation plays an important role in terms of symptoms and outcomes in ischemic heart disease. So now, what is the coronary microvascular dysfunction, CMD? This is a patient information article published in JAMA, and they defined it as abnormal dilation and constriction of the coronary microvasculature. It is also mentioned that most people with CMD are women, and its risk factors include hypertension, diabetes, dyslipidemia, and smoking. Then what is the pathophysiology of CMD? So coronary circulation consists of two main components, the epicardial arteries and the microvasculature. So epicardial arteries are the conductance arteries, typically larger than 500 micrometers in diameter. So under normal conditions, these epicardial arteries contribute only 5% of the total coronary resistance. So the coronary microcirculation include the prearterioles, intramural arterioles, and capillaries. And these small vessels are responsible for more than 90% of coronary resistance. So essentially, myocardial oxygen extraction is near maximal under normal condition. So any increase in oxygen demand must be satisfied by increasing coronary blood flow. So this is achieved by vasodilation of microcirculation, which allows to increase coronary blood flow up to 5-fold. This is a diagram showing the multiple mechanisms behind CMD. Roughly speaking, functional changes, structural changes, or a combination of both. The functional mechanisms are shown in the red box, which is impaired vasodilation and increased vasoconstriction. So these factors are closely related to endothelial dysfunction and impaired relaxation of vascular smooth muscle cells. And structural mechanisms include arterial remodeling with intimal and medial wall thickening, and perivascular fibrosis, as well as the capillary rarefaction, and often in the setting of increased LV mass. So these changes are seen in specific conditions such as hypertrophic cardiomyopathy and hypertensive heart disease. So why CMD is important? So here is a case from our center, a 75-year-old female with exhaustional dyspnea. So rubidium PET was performed. The perfusion was normal, as you can see here, both at rest and stress. And also gated images showed normal LV wall motion, and LV function was fine. This is a flow data. The resting flow was normal, 0.81 global, whereas stress flow was globally reduced, 1.32. Myocardial flow reserve was 1.62, which is mildly reduced. We often use the 2.0 as a cutoff. And this is a typical finding of coronary microvascular dysfunction without obstructive epicardial disease. Subsequently, coronary CT angiography was performed, and it was confirmed that there is no obstructive lesions in the epicardial arteries. The clinical presentation of coronary artery disease has changed over the past few decades. Up to 70% of patients undergoing coronary angiography for angina have no obstructive CAD. So this scenario is referred to as ischemia with non-obstructive coronary artery disease, INOCA. And we know that CMD is one of the mechanisms responsible for INOCA. This is the data from ischemia trial. So among patients with moderate or severe ischemia, the prevalence of INOCA was actually 13%. They have shown that INOCA was associated with female and younger age. And interestingly, the severity of ischemia was not associated with the extent of atherosclerosis on coronary angiography, coronary CT angiography. And it is also known that CMD is associated with a variety of cardiac diseases, such as heart failure with preserved ejection fraction, Takotsubo syndrome, post-PCI or post-CABG angina, hypertrophic cardiomyopathy, and aortic stenosis. So therefore, evaluating CMD would be important for managing these conditions. This is a case of Takotsubo syndrome. As you can see here, there is moderate perfusion defect in the apical segments and apex, which improves at rest. So summed stress score, SSS, was 12, and summed rest score was 5, and summed difference score, which is indicating the amount of ischemia, was 7. So in terms of the flow measurement, the rest and stress MBF were both reduced, 0.93 and 1.41 respectively, and in the mid to distal segments and apex. And this is consistent with perfusion findings. And also MFR, the flow reserve, was globally reduced, including the basal segments. So this patient had follow-up PET in 6 months. As you can see here, perfusion defect has gone, a normal perfusion at less than stress. And additionally, LV wall motion improved to normal. Similarly, all flow parameters were normalized. So this is a good example showing the reversible microvascular dysfunction typically seen in Takotsubo syndrome. Recently, we analyzed the PET findings in patients with Takotsubo syndrome. Looking at the left panel, and you can see that the prevalence of abnormal MFR has decreased from acute phase to chronic phase. And the right panel is showing the comparison of the flow parameters between baseline and follow-up in patients with serial PET scans. So obviously, all flow parameters, I mean, less MBF, stress MBF, and MFR improved significantly at the 6 months follow-up. So I didn't put the detail on this slide, but if you look at the segmental PET parameters, the extent of microvascular dysfunction is not localized in the apical segment, but extends to basal segments. So I'm assuming that the Takotsubo syndrome is more global disease rather than a focal disease, which is typically seen in the wall motion abnormalities. I shared 2 case examples so far, but in fact, there are many other cardiac conditions associated with CMD, as shown in this figure. Among them, I'm really interested in HFpEF, which I think is one of the hot topics in cardiology. I'm currently analyzing the PET data in patients with HFpEF. We really need to understand that CMD affects a wide range of patient population and is therefore extremely relevant to our clinical practice. So additionally, CMD is related to worse patient outcome. So this is the data from recent meta-analysis showing that CMD associated with 4 times increase of mortality and 5 times increase in MACE. So therefore, patients with CMD should be detected and managed properly. All right, so now how can we diagnose CMD? Although there is no established diagnostic strategy for CMD, the 2021 AHA and ACC chest pain guidelines include diagnostic strategy for INOCA. Looking at this, invasive coronary angiography with functional testing has a 2A recommendation. Similarly, PET and MRI has a 2A class recommendation, whereas TTE has a class 2B recommendation. So now let's walk through each modality. Invasive assessment is essentially based on invasive coronary angiography. Some people argue that coronary slow flow phenomenon may be a surrogate for CMD, particularly in the setting of non-obstructive CAD. This is the video showing coronary slow flow phenomenon. This is my own case back in Japan. The velocity of the contrast is relatively slow, and the washout is also delayed. So, however, it should be noted that recent article questions the association between the CMD and coronary slow flow. So I think this should be further evaluated. So flow measurements with intracoronary wire is the most validated method. Hyperemia can be achieved by injecting adenosine or papaverine into coronary arteries. This can be performed with pressure thermistor tipped wire or Doppler tipped wire. So both can measure coronary flow reserve, and typically 2 or 2.5 is used for the cutoff. An intracoronary provocation test is also important because this is essential for the diagnosis of coronary vasospasm. And typically either acetylcholine or ergonovin is injected into the coronary arteries, and then ischemic ECG changes and reproduction of the angina symptoms are evaluated. This is an example of epicardial coronary vasospasm. And so there is no significant stenosis at baseline on the left panel. but after ergonomine injection, there is diffuse narrowing of coronary arteries, which is suggestive of vasospasm. And importantly, soon after the injection, the patient complained of angina with ischemic ECG changes. This is also my case, and therefore the diagnosis of multivessel coronary vasospasm was confirmed in this case. So there are two key parameters for invasive CMD assessment: coronary flow reserve, CFR, and index of microcirculatory resistance, IMR. So CFR is essentially a ratio of resting blood flow to maximal hyperemic flow. And IMR is defined as the product of distal coronary pressure and mean transit time over saline bolus during maximal hyperemia. And it is important to remember that the CFR represents both epicardial and microvascular function, whereas IMR represents microvascular function only. So this is an example of CFR and IMR measurements. As you can see on the angiogram, there is no obstructive CAD. However, CFR was 1.5, which is below 2.0, and IMR was 40, which is greater than 25. So these findings are consistent with microvascular dysfunction. One of the recent topics in this area is angio-IMR. So traditionally, IMR measurements require the insertion of the pressure wire, as I said, but this increases the procedure time and cost, as well as the risk of complications. So now there is a new approach, angiography-based IMR. So this index computes from coronary angiograms and then does not require the wire insertion or adenosine injection. So importantly, you can measure FFR simultaneously, so which enables comprehensive functional assessment. More recently, it was found that angio-IMR has prognostic value. So this is a paper published in JACC Intervention this year. It was shown that angio-IMR is a prognostic marker in patients with obstructive and non-obstructive CAD, regardless of the application of PCI. So this result has a great impact on our daily practice because it's easy to do post hoc analysis for angio-IMR. I believe this technology will be widely used in the future. Okay, now we will move on to the non-invasive assessment. Currently, there are 5 options: echo, CT, MRI, PET, and SPECT. So the main focus today will be on a PET and SPECT, but I will briefly touch on other modalities as well. As for echo, there are 2 approaches: contrast echo and Doppler echo. The contrast echo has very few validation studies for CMD, unfortunately, whereas the Doppler echo-based measurement was shown to correlate well with invasive measurement. However, just keep in mind that only LAD territory can be assessed with this technique, so applicability would be very limited. And obviously, echo-based measurement is highly operator-dependent and affected by the patient body habitus. CT is also an option. A major advantage here is that it allows for the evaluation of both coronary anatomy and myocardial perfusion within a single study. And however, quantifying coronary blood flow requires dynamic perfusion CT scan, which involves acquiring multiple sequential imaging during contrast infusion. And this increases radiation exposure significantly. And additionally, there is concern that contrast-induced vasodilation could lead to an overestimation of the coronary blood flow. So therefore, this technique is not widely used so far. There is another potential CT parameter to assess CMD, the ratio of coronary lumen volume to LV mass, which is called VM ratio. As you can see on the left panel, coronary lumen volume and LV mass can be estimated by using post-processing software. And it has been shown that there is a correlation between invasive FFR and VM ratio, as shown in the right panel. Additionally, Vancouver group has shown that patient with microvascular angina has a significantly lower VM ratio. Therefore, VM ratio is a potential marker for CMD. So now, cardiac MRI, so MRI can also measure coronary flow. No radiation required. Spatial resolution is excellent. Most importantly, MRI provides a comprehensive assessment of cardiac anatomy, and morphology, and functionality, and myocardial perfusion as well. In particular, T1 mapping and LGE sequence are very helpful in tissue characterization. Therefore, MRI is particularly useful in patients with underlying disease, such as hypertrophic cardiomyopathy and cardiac amyloidosis. Disadvantages here include high cost, limited availability, and limited applicability to patients with implantable devices and claustrophobia. Okay, let's move on to PET. So PET is currently the gold standard for non-invasive assessment. PET has good reproducibility and accuracy with extensive prognostic data. However, there are a couple of things to keep in mind. First, it's important to remember that several factors can affect the quantification of coronary blood flow. We need to consider the radio tracer, the pharmacologic stress agent, and the PET system, as well as the post-processing software. We also know that biological variables such as age, sex, and genetics can change flow values. Last year, Sperry and colleagues published very important data on age and sex-specific flow values in patients without obstructive CAD. They analyzed more than 2,700 rubidium PET scans in patients with no perfusion defect, no coronary calcium, and normal LV function. So looking at these figures, MFR is higher in younger male than in younger females. MFR decreases with age in both sexes. And looking at the figure on the right, MFR of 2.0 is okay in the elderly, but it's probably abnormal in the 20s and 30s. So therefore, it's important to remember that you should always consider age and sex when you evaluate the MFR. What about the repeatability of measurements? Actually, it's quite consistent. LEST MBF has a variability of about 2.0. And regarding stress MBF, same-day testing shows a coefficient of variation of around 10%. And it increases up to 15 to 20% for different day measurement. And this should be taken into consideration when you evaluate serial PET scans in the same patient. A few words about the clinical significance of each flow parameters. The stress MBF reflects both microvascular and epicardial vascular performance. Reduced stress MBF may indicate early structural or functional problems in the epicardial or microvascular compartments, even without obstructive CAD. In terms of LEST MBF, it is determined largely by oxygen demand. Conditions that increase heart rate and blood pressure, or LV wall stress, or even sympathetic tone can increase the LEST flow. MFR is the ratio of stress flow to LEST flow. So this shows how much the coronary arteries can increase blood flow. A reduced MFR can occur if left flow is high or the stress flow is low. When we talk about cutoff values, most centers use less MBF cutoff somewhere between 0.5 and 0.8, and stress MBF between 1.7 to 2.3. But again, this can vary depending on age and sex. In general, females tend to have higher value for both less and stress MBF as shown in this figure. MFR below 2.0 is widely accepted as indicating coronary microvascular dysfunction. However, some studies suggest that more strict MFR cutoff, such as 1.7 or even 1.5, may carry stronger prognostic value. This is data from our center. Dr. Tabosi and colleagues evaluate PET flow parameters in patients with angina with non-obstructive CAD. Among 50 patients, 26 patients were diagnosed as microvascular angina, and patients with microvascular angina had a reduced MFR compared to those without. And interestingly, the optimal MFR cutoff was actually 3.12 for diagnosis of microvascular angina in this population. So this result makes me wonder that the MFR cutoff should be defined in each patient population with the clinical context. So in my mind, using a single cutoff like 2.0 would not be reasonable, but of course, this needs further evaluation. So now I would like to introduce another PET parameter, coronary vascular resistance, CVR. CVR is calculated by dividing mean or systolic arterial blood pressure by MBF. So CVR takes into account the coronary driving pressure. Therefore, it is considered to provide a more accurate measure of microvascular function than simply looking at blood flow. So this is the similar concept with IMR on the invasive assessment. Dr. Chi and colleagues evaluated the association between PET flow parameters and the incidence of allograft vasculopathy in patients undergoing heart transplantation. So they found that increased CVR was associated with allograft vasculopathy, which is related to coronary microvascular dysfunction. And in addition, when evaluating the correlation between IMR and CVR, there was a moderate but significant correlation between the two. So therefore, we often include CVR values in our clinical PET report, especially for heart transplant patients. We are also trying to expand the application of CVR to CABG patients. Dr. Small and I myself analyzed data from 556 patients with history of CABG and looked at the association between PET flow parameters and prognosis. So MFR less than 2.0 was associated with worse outcome, and similarly, CVR greater than 60 was associated with worse outcome. When we classify the patient into 4 groups based on CVR and MFR, there was a significant difference in prognosis between 4 groups. If both CVR and MFR were normal, patient has significantly better prognosis, which is shown in black. And whereas if both were abnormal, the prognosis was worse, as shown in the blue. If either was abnormal, the prognosis was intermediate. And moreover, multivariable analysis confirmed that both CVR and MFR were independent prognostic predictors of MACE. So based on these findings, we believe that incorporating both MFR and CVR improves the prognostic value of PET. A few words about interpretation nuances. When interpreting flow parameters, it's always important to make sure that patient had an adequate response to vasodilator stress. Splenic switch off is useful to evaluate this response. So hemodynamic changes during stress is also helpful, but I would say heart rate and blood pressure changes are sometimes inaccurate. So coronary artery calcification also provide crucial context. In the setting of reduced MFR, few calcification increase the likelihood of severe microvascular dysfunction, whereas the moderate to severe coronary calcification suggests advanced coronary artery disease. And it's also important to note that global MBF, global value, can mask regional variations, potentially masking focal area of reduced flow. So I'm always trying to see regional flow abnormalities when reporting PET. Here is an example of the absence of splenic switch off. The relative perfusion images are normal, as you can see here, but the MFR was globally reduced 1.06. However, when you look at the spleen, there is no reduction in splenic uptake during stress. So this is a typical pattern of a non-responder to vasodilator stress. And the scan was repeated after 36 hours of caffeine abstinence. This time, the MFR was normal, 3.34, and you can clearly see the splenic switch off. The mechanism of splenic switch off is thought to be a consequence of splenic blood flow reduction through A1 and A2B receptor-mediated vas constriction by adenosine. Splenic response ratio, SRR, is a quantitative measure of splenic switch off. So SRR can be measured by this formula using SUV values in spleen and liver. So the suggested cutoff value is 0.79 with sensitivity of 78% and specificity of 69%. We sometimes use this quantitative measure when the visual assessment of splenic switch off was inconclusive or kind of borderline. Okay, so the last modality is SPECT. Similar to PET, SPECT can be used to quantify myocardial blood flow when using a next generation camera, which is CZT camera. So there is growing evidence supporting the accuracy of and reproducibility of SPECT-based MBF measurement. Compared to PET and cardiac MRI, the SPECT is more widely available, as you know. So given its accessibility, SPECT can play an important role in the evaluation of CMD in the future. This slide compares time activity curves acquired with SPECT and PET in patients with LAD stenosis. The top panel represents data acquired with CZT SPECT. While the lower panel corresponds to PET. So the red line indicates blood pool activity, whereas the blue line represents myocardial uptake. The light blue shows the fitted model data. And as you can see, the time activity curves are very similar between the two modalities. And similarly, the perfusion and polar maps demonstrate comparable results, showing reduced uptake and flow in the LAD territory. And this was the first validation study of SPECT MBF measurements conducted by Dr. Wells and Dr. Reddy and colleagues. The results demonstrate a good correlation between global MBF and MFR measurements obtained with SPECT and PET. And importantly, this correlation remained consistent regardless of the use of attenuation correction. But one of the issues with SPECT-based flow measurement would be the additional time to complete the scan. This is the data from international multi-center studies showing the extra room occupancy time for measuring MBF in SPECT studies. In our center, we needed 52 minutes additional time compared to conventional SPECT scan without flow measurement. Some centers had longer time. For example, one of the Japanese centers required 78 minutes of extra time. The average of additional time was approximately 60 minutes. So this additional time would worsen the patient throughput, which may lead to increased costs and medical resources. In this context, we are working on developing a rapid protocol for SPECT MBF measurement. The protocol starts with positioning dose of radiotracer and imaging, followed by a less injection of radiotracer with dynamic imaging. And this is followed by a dipyridamole stress test with radiotracer injection and dynamic imaging. So prone imaging can be added to assess attenuation artifacts. In this protocol, static perfusion imaging is reconstructed using dynamic list mode data, so we can eliminate the need for conventional delayed imaging. The same approach can be used for stress imaging. So we can therefore reduce the total scan time to about 40 minutes. The concern is possible greater extracardiac activity on early images constructed from the dynamic data. The defect related to the extracardiac, so this is an example, this is an example of the possible problem with early imaging. The red arrow points to an inferior, extracardiac activity on early images, and the yellow arrows points to an inferior defect. The late images has less extracardiac activity and lesser defect. So we analyzed the differences of perfusion parameters between early images and late images. While early images showed more extracardiac uptake. However, perfusion defect patterns remained highly similar. There was a strong correlation between the sum stress score and sum less score. So therefore, our rapid protocol using early dynamic imaging alone appears to be feasible and a time-efficient option. Of course, further validation studies, including comparison with PET scan and multi-center evaluation, would be necessary. Okay, so lastly, I will talk a little bit about treatment options for CMD. To date, there are no specific treatment recommendations for CMD because of the lack of evidence. However, the main goals here are to reduce the risk of adverse cardiovascular events and to improve the anginal symptoms. Atherosclerosis targeted therapies include aspirin, statin, ACE inhibitor, and ALVs. And anti-anginal medications include beta blockers, calcium channel blockers, and nitrates. And non-pharmacological therapy includes aerobic exercise, weight loss, and smoking cessation. So these non-pharmacological therapies were reported to be beneficial for CMD. One of the recent topics include coronary sinus reducer. This device consists of a metal mesh device pre-mounted on a balloon catheter that is hourglass shaped when expanded. The coronary sinus reducer is designed to increase venous pressure and distribute blood flow from non-ischemic segments to ischemic segments, thereby reducing anginal symptoms. A recent paper published last year in JACC Intervention showed that coronary sinus reducer improves angina, quality of life, and coronary flow reserve in patients with microvascular dysfunction. This is a small study including only 30 patients, but coronary sinus reducer could be a potential treatment option for CMD. Finally, I would like to briefly introduce our ongoing research project on inspiratory muscle training. BREATHE trial is a randomized control trial that is designed to evaluate the effects of inspiratory muscle training on coronary blood flow. Inspiratory muscle training is a new form of training, aerobic training, which aims to strengthen respiratory muscles such as diaphragm and intercostal muscles. So this training uses specific training device, which is called Power Breathe. This training is primarily used for patients with lung diseases such as asthma or COPD, as well as post-surgical patients. However, it is also known to be beneficial for patients with heart failure. And recent studies have shown that inspiratory muscle training improves endothelial function by increasing the bioavailability of nitric oxide. And this suggests potential vascular benefits of the training, leading to our research hypothesis: inspiratory muscle training may improve coronary blood flow and ultimately help reduce angina symptoms. We also hypothesize that IMT or this training may serve as a potential treatment for patients with INOCA or coronary microvascular dysfunction. We often think that the diaphragm is just a respiratory muscle, but it actually plays an important role on cardiac function. Beyond breathing, the diaphragm acts as a pump, assisting with venous and lymphatic return. And it controls left ventricular afterload and influences pericardial pressures and even regulates autonomic tone. So that's why the diaphragm can be the therapeutic target. And we have completed patient enrollment for this BREATHE trial, so we are expecting the results to be available soon. In conclusion, CMD arises from both structural and functional changes in the coronary microvasculature. And CMD occurs in various cardiovascular conditions and significantly affects clinical outcomes. Several imaging modalities are now available to measure myocardial blood flow in patients with suspected CMD. PET is the most validated and clinically available non-invasive imaging modality. SPECT MBF can be alternative to PET. And to develop targeted therapies for CMD, further studies are needed. Finally, I would like to thank all of my supervisors. So they are all very supportive and encouraging for both clinical work and research. And these are my colleagues, including not only cardiology fellows, but also radiology fellows and nuclear medicine fellows. We collaborate with each other all the time, and they are very enthusiastic, and I'm always motivated by them. And also, I would like to thank my family for their support. Thank you for your attention. Thank you.
And we'll take some questions from the room first. I have a relatively straightforward one. So PET's great because we get lots of different parameters, but the trouble is some of those parameters, one that comes up frequently is abnormal flow. How do you handle that?
Thank you for your good question. So a couple of things. In that situation, I would first confirm there is response to vasodilator stress, as I mentioned in the slides. So if there is good response, I'm going to look at the CT coronary calcification. If there are a lot of calcification, that means perfusion might be underestimation. I mean, it's false negative. And I would believe the flow data. But if there's no coronary calcification and younger age and female sex, that would be likely to coronary microvascular dysfunction. So we need to consider all the clinical context, I think. We always, consider the background of the patient. Thank you so much. If we suspect coronary microvascular dysfunction rather than coronary obstructive coronary artery disease, we would order a PET scan first because it's most validated and most it's feasible in our center. So PET, I think PET is mostly ordered. But as I show in my slide, the SPECT MBF, I think, can be alternative. SPECT MBF can be reliable if protocol is appropriate. So I think, and then I don't know if the MRI, how feasible MRI is here, but but the SPECT can be.
It's an interesting topic, and SPECT blood flow is can be quite technically challenging. So I think you guys are fortunate to have Glenn.
Thank you for your very good questions. It's very important question. As I mentioned in my presentation, the problem is we don't have validated treatment options for coronary vascular dysfunction at this moment. So in terms of the adverse cardiovascular events, we have a couple of options like medication, aspirin, statins, those kind of things would probably help. But in my mind, we have to establish the non-pharmacological therapeutic options. And then in my mind, the like exercise can be promising options in my mind. There's no established evidence so far, but as I show in my slide, I didn't include my BREEZE trial results, but some patients improve significantly after the training. This is amazing result. Actually, I'm analyzing the data so now. I can't show you the results right now, but some people with impaired flow reserve, after the 6 weeks of training, of breathing training, the MFR improves significantly. So I believe this kind of exercise training can help in microvascular dysfunction. We include healthy people as normal people as well, and we haven't compared those, between the normal and abnormal patients. But yeah, normal patient may not be. It might not be beneficial. I don't know. We don't know the answer so far, but yeah, it's still under investigation. But it's quite important question. Thank you so much.
I had a follow-up question too. So, phenotyping people with microvascular disease or like obstructive coronary disease is a big. But how do you use that information or
Yeah, that's also important. So obviously, if the patient has vasospasm, the calcium blocker or nitrates would be recommended. Um, so yeah, so phenotyping is very important. So if I didn't include so there is a specific algorithm for treatment. I think it's published in the I don't remember, but some articles, and then after the phenotyping, we can choose the appropriate treatment. So vasospasm would be the first thing we should exclude or identify, because there is a specific treatment options.
well, that looks like a two-part question, and it's, is there a relationship between microvascular dysfunction and endothelial? And are you aware of any trials of colchicine for?
Thank you for the question. The one of the mechanism coronary microvascular dysfunction include endothelial dysfunction. So for sure, there is a relationship between coronary endothelial dysfunction and coronary microvascular dysfunction for sure. Colchicine, I don't have any experience or idea about colchicine, but this is anti-inflammation medication, so that might be helpful, but I have no idea at this point. Sorry. Oh, that's a difficult question. To be honest, I have no idea about that. I've never heard of kind of. Do you know that?
Yeah, I was going to say, I'm not aware of anything quite like that. Like there's lots of metabolism-based tracers.
I myself have a question about CMR. Um, I'm really interested in the flow quantification on CMR. But what do you think about cutoff value for CMR? So most papers uses 2.0. Probably it's coming from the PET data or other modality data, but different modality might have different cutoff or, I mean,